You're listening to Beyond Wellness Radio, bringing you the cutting edge in health, biohacking, and sports performance. Stay up to date and listen anywhere and anytime on your computer, tablet, or smartphone by subscribing on iTunes. Catch your host, Dr. Justin Marchegiani, as he answers your burning health questions as well as interviews from world-renowned guest experts. For more Beyond Wellness Radio, go to beyondwellnessradio.com.
Hey there, it's Dr. Justin Marchegiani. Welcome to Beyond Wellness Radio. Feel free and head over to beyondwellnessradio.com where you can access our full podcast transcriptions. While you're there, you can also sign up for our thyroid and female hormone video series. This series goes into the root cause of why your hormones are out of balance. While you're there, you can also schedule a functional medicine consult with Dr. Justin, myself, where we'll dig deeper into the root cause of your health challenges. Feel free and think of sharing this podcast with at least one person. This podcast grows by people sharing it. Sharing is caring. If you can think of one person that can benefit from this information, please feel free and share it. If you're enjoying the podcast, make sure you subscribe on iTunes. You can also click below the video or podcast where you'll see the iTunes review button and leave us a review. You can also sign up for the newsletter at beyondwellnessradio.com where you'll get updates before anyone else. Thank you so much and enjoy the show. And we are live. It's Dr. J here in the house with Evan Brand. Hope everyone is doing fabulous here today. We are going to be talking about the importance of gut testing. Super, super important. There's a couple of modalities that we use kind of at our functional medicine tool belt, and gut testing is super important. We're going to kind of go in the ins and outs of gut testing, why it's important. We're going to break down some of the GI map actual testing as well, and we're going to go through what a typical test looks like, what we're actually assessing, what we're looking for, infections, functional analysis, other intestinal health markers like inflammation, IgA levels, beta-glucuronidase, steatocrit, elastase. We're going to break it all down. We're trying to bring everyone actionable information that, a lot of doctors, a lot of people you see online, they're not really seeing patients. So a lot of the stuff they talk about is kind of theoretical and it's not really applied. So everything that we're talking about today has actually been applied with thousands of patients. So hoping everyone enjoys. So while we're on topic, Evan, how are we doing today, man?
I'm doing pretty good. I'm trying to look for a stool test that's like really bad because it's more fun, right? When you see ones that just have tons of infections on there and different things. I've got a good one here that we can dive into. I was just trying to find one with a high beta-glucuronidase because that was one key point that I wanted to talk about with you, is that many people are sick because of having high beta-glucuronidase, which is an enzyme that goes high due to bacterial overgrowth in the gut. And so many people talk about, well, you've got to take calcium D-glucarate, right? People discuss calcium D-glucarate as a supplement to help lower high beta-glucuronidase. Now, this is like your average person at the grocery store is not going to have this conversation, but we're talking in the functional medicine world. If you're working with a practitioner, they may look at you, and if they know what they're doing, they may say, hey, yeah, you should probably do calcium D-glucarate. But that's not root cause. The root cause is figuring out, why does this person have high beta-glucuronidase in the first place? Yeah, we can take nutrients to lower this, and we can take nutrients to lower inflammation, but we always have to work backwards. So why don't we talk about the backwards piece? What are the contributing factors to the gut inflammation we're seeing? What are the contributing factors to the secretory IgA being low? Why does this happen?
So first thing first is we have to do an adequate history. How did we get here? That's like the first question that everyone needs to be asking themselves, and their functional medicine doctor needs to be kind of reviewing with them. So a lot of people, there's usually a history portion that reveals this. So when I come in and I do a history, I do a timeline history, I try to figure out how the person got here. So there's two scenarios. There's either the person got to this position where they're sick and not feeling well acutely, i.e. I was in Mexico, I ate some bad food, now I'm sick. Or most of the time there's a chronic insidious bit to it, where there's been some stress, emotional stress, physical stress, chemical stress, bad foods, poor digestion, and then the kind of stress has been going in a downward pattern. Health symptoms have been getting worse over time, and then boom, they get sick acutely, but it's not really acutely. There's been a downhill kind of spiral the whole time. So number one, there's totally acute feeling great, now they're not. Number 2, it's this chronic downward decline. Boom, they get sick. And I'd say number 3 is it's just chronic and there's no timeline, there's no event at all. It's just a gentle downward slope. So 3 ways that kind of health symptoms unfold. 1, very acute. 2, a downward decline followed by an acute episode, and it could be a couple of acute episodes, by the way. It may not be one, and a lot of times there could be an autoimmune flare involved in there. And number 3 is it's just a gentle downward decline with no acute episode. So those are the big 3 scenarios. So we have to really look at, hey, when was the last time you remember yourself feeling good? Walk me through the timeline over the last 10, 15 years. When did things start to go sideways? Was it when you were eating some bad food, some gluten? Was it when your diet was poor? Was it when stress or sleep was poor? Was it when you started going through menopause or having some hormonal issues? Was it when you had a thyroid flare? What was going on when all this stuff happened? And those are the important questions because we have to connect the dots to the root cause. So when we ask questions about symptoms that are downstream, we're actually looking upstream to the root cause that cause these symptoms to manifest. So there's a different mindset. Most clinicians and doctors are looking at, hey, what medication can we do to cover up that symptom? Or even what supplement or nutrient or herb can we use to cover up that symptom? But we may be looking at that too, but we're also looking upstream as well.
Yeah, a couple other triggering factors. Divorce is huge. So any issues with marriage, whether someone just had a bad marriage and needs to divorce, but they haven't yet, they did get a divorce. Like I had a woman last week who developed Hashimoto. She developed thyroid antibodies after her divorce. She had blood work done before. She had no antibodies. She went through crazy stressful divorce, fighting over who gets the kids and all that. And then boom, you look at the labs and then there's the antibodies that showed up as sort of a response to the major stress.
Yeah, of course. And ideally, when you deal with marital stress, ideally you're on top of it and you're seeing a counselor to help because it's always easier to mend it than to walk away. Some situations you can, some you can't, but we always recommend getting some kind of counselor in there to help on that side of the fence. And then, of course, death of a loved one is going to be a big one. Even things like moving. And a lot of times moving may be tied to a promotion or a good thing, but believe me, it's very stressful. If we look at what's called the social adjustment questionnaire, moving, death of a loved one, death of a child is even more. Affairs, divorce, anything on the relationship side is really big. So those are going to be important things you want to look at from an emotional stress standpoint because those can be a big thing. And they put stress on the adrenal glands. So, hey, we just want to make sure that we're addressing it, we're processing it, we're seeing a counselor, we're seeing a therapist, someone to work on it. Maybe there's subconscious stress. Maybe we're working on EFT or NLP or EMDR techniques to deal with the PTSD from that trauma. So we have things like that, right? And then, of course, like in your timeline history, we're also going to be looking at, was there a leak in your house? Was there any mold exposure? Things like that, because that's a big environmental pull. Hey, do you feel better when you leave your house for a week? Barring the fact that you may be on vacation and stress is lower. If you just leave your house for a week, do you feel better? So we like to have those kind of timelines because that can, so I digress, but that can set you up for a whole bunch of gut issues. So when we talk about gut testing, it's never just the gut myopically. We're trying to connect the gut to underlying stressors that have been accumulating for years, if not decades, that got you to this position to begin with.
Yep, well said. Well said. Yeah, the mold piece is huge, because people move, so you have the stress of moving, but then you're moving into a house that's moldy. So you and I countless times now, we've seen people where it's like, okay, what happened in the last few years? Your health went downhill. Well, I moved 2 years ago. Oh, okay, when you moved into that house, did you get worse? Yes, I did. Okay, let's test it. Boom, there's a big smoking gun. And now we know, just with the help of some of these laboratories that look at mycotoxins, they'll tell you straight up, the papers look at mycophenolic acid, a major mycotoxin. It damages the gut barrier, so this is a new cause of leaky gut beyond infections. Also, it promotes the growth of candida, which disrupts your gut and your brain function, and it promotes the growth of Clostridia bacteria, which we often see. So now we have the root cause of the root cause, meaning, okay, these people keep treating candida, maybe with a naturopath where they do herbs to kill candida, and then it keeps coming back. Why is it coming back? Well, now I know mycotoxins are one of the big triggers. But let me share my screen.
Yep.
Let's go into this. I've got two different ones here that I want to talk through with you. And,
let's do it.
So, two different situations. Both of the people had similar symptoms, just in terms of mood issues, depression, anxiety. But the one on the right here, on my right here, this is the one that's moving. This one is...
I want to just highlight one thing here for people. So this first page here, a lot of the pathogens on the first section, bacterial pathogens, these are typically food poisoning type of pathogens. C. diff, toxin A and B, when you have both, is more serious. You can get these from antibiotics, hospital setting primarily, Campylobacter, and then a lot of the E. coli, whether it's the enterotoxigenic hemorrhagic E. coli or the O157, or the various Shigella toxins, which are part of the E. coli spectrum. Salmonella, cholera. Yersinia is kind of like a parasitic bacteria. These are usually going to be food poisoning situations, with the exception of C. diff, more hospital setting or antibiotic setting. And then, of course, the parasite section, there's others on page 4 on this test, but these are some significantly big ones. Crypto, Entamoeba histolytica, or EHISTO for short, Giardia, and then, of course, some of the viral issues would tend to be more self-limiting. But the biggies here are going to be the parasites and more of the food poisoning or hospital-based infections above. All right, go ahead, Evan.
Yeah, and I'm going to make a pretty link, which is a link that will redirect you, because if you're listening on audio, this is not going to be as exciting. So if you're listening to my podcast, you can just type in evanbrand.com, and I'm going to make the link MAP. So evanbrand.com/map, MAP. That's going to take you to Justin's YouTube channel, where you can view this if you want to kind of follow along. But yeah, so on these two particular cases, nothing showed up on page 1. Everything's below detectable limits. A lot of times we'll see crypto and Giardia, though. If we've got somebody that's got weight loss or weight gain issues, we've got stomach cramping, we've got diarrhea. And the interesting thing is, too, this time of the year when we're talking towards the end of November, we'll have a lot of people that will come to us with more acute issues. And when we look at the acute issues, a lot of times the noroviruses will show up, and we can give some support, but a lot of times those things just have to run their course.
Yeah, a lot of times they're self-limiting. We can do things like high-dose silver. So in my line, we'll do GI Clear 3, which is a silver compound, or nanosilver. We can also do monolaurin as well to kind of help knock those things down. We can even just do high-dose oil of oregano. So in my line, GI Clear 5 is an emulsified oil of oregano, very high dose. That can be helpful. GI Clear 3 is a nanosilver. So a good nanosilver, a colloidal silver, can be helpful. And a good monolaurin, which is an extract from coconut, all have great antiviral benefits too.
Yep. So here's page 2. Now, as I mentioned, the one on the right here, this person is more sick symptomatically, and we already see one reason why. You see the H. pylori at the top of page 2 here, and this is like an exponential scale. So it goes E3, E4, E5, whereas the person on page 2, they've just got a lot of stuff going on with their normal flora being too low. You've got some that are showing up too high. But obviously, page 2 here, the H. pylori is going to be the biggest smoking gun for this person on the right.
So let's kind of hit it one by one. So we have the H. pylori section. So one thing to highlight is the standard deviation. I have a lot of patients that freak out, that don't quite get it. So, unless you've taken a stats class or a physics class, it's weird, right? I wish the lab didn't use the standard deviation, meaning e to the 5, e to the 4, whatever. So when you see the reference range is e to the 3. So the average person would look at this and say, oh, well, the range is greater than 1. This is 1.2. That's only a little bit elevated. Not necessarily, because this is e to the 3 over here to the right, and this is e to the 5. So to equal it out, you have to move the decimal place to the right 3 times. So when you move it to the right once, now it becomes 12 e to the 4. And then when you move it again, now it becomes 120 e to the 3. So now when you look at it, it's actually 120 times above the normal limit. So that's important, because if it's 120 versus only 1 time above, that tells us the infection is probably a lot more serious from an overall load standpoint. Does that make sense?
It does.
And people confuse that. And it's okay. It's not normal, right? Unless you've taken those classes, you're not going to know it. So, and if people look at it first time around, it's just confusing. The lab could do a better job at that, but that's where we're at. And then if you look at the virulence factors below, these are cytotoxic proteins that are produced by the infection. So you can see this person on the right, and people listening will have the links for these labs. So if you want to click on the link and follow along and look at the lab with us, we also have video format. So if you want to see the video version, it walks you through it that way. So you see these virulence factors. So one of the bigger ones is going to be the VAC-A. The VAC-A and the CAG-A are the most research on those two. But these are cytotoxic proteins that are being produced by the infection that give it greater chance of inflammation, ulceration, cancer, etc. So it tells us the infection's stronger. That's all it is. It's like, oh, this infection has a little bit more muscle or meat behind it, so to speak. So you could still have problems without the virulence factors being present, but if we see virulence factors and a strong amount of H. pylori, well, then we know that this infection is probably a lot more serious and we have to handle it, sufficiently. But either way, if we see even a borderline number on the H. pylori, then we're still going to address it and make sure we knock it down. Any comments there, Evan?
I've seen multiple people that have had a history of stomach ulcers. And those people with a history of stomach ulcers do tend to show up with some of the virulence factors. And there are some papers on that. We've got a white paper on this where we can look at the different virulence and see what they're associated with. Some is long-term inflammation, some is long-term infection, some is increased risk of stomach cancers and esophageal cancers and all that. So these are very helpful. And if we do see them positive, we always put a huge emphasis on it.
100%. Next, we have the normal bacteria. And so this is normal good flora, or I should say normal beneficial flora in the gut. So like when I say that, there are two that are probiotic species, like, the ones you think of as probiotics. Those are going to be your lactobacillus and your bifidobacter species. And there's a lot of different lactobacillus. There's lactobacillus paracasei, acidophilus, reuteri, right? A lot of different kinds. There's Bifidobacteria longum, etc. So there's many different species. The Bifidobacter and the Lactobacillus kind of lump all of those into one. These are what we consider our probiotics. And everything in this section is a normal bacteria. So when you see Akkermansia muciniphila high, okay, that's on the higher side. Is that an infection? Is it a dysbiotic bacteria? Not necessarily. We're not going to worry about it too much. These things kind of take care of itself, and I'll go into that. You can see this person has a lactobacillus is low, right? So that's a beneficial bacteria. So I'm already leaning into the fact this person probably has a dysbiosis, meaning higher amount of bad bacteria in relationship to good bacteria. And so you can see here below, this is the types of bacteria. And then the phyla, think of phyla as family. And there's two general families of bacteria. There's the Bacteroides family. Think Bacteroides, beautiful. And then Firmicutes, think of Firmicutes as fat. Now, what does that mean? Firmicutes bacteria tend to have the ability to overabsorb calories. So when we see higher amounts of Firmicutes, overabsorption of calories. And again, some of the studies on this are weak. They're more mice-based studies. Higher levels of Firmicutes increase weight gain in the mice due to calorie absorption. Think of Bacteroides as beautiful, helps, it does the opposite of gaining weight, keeps you leaner and healthier, right? So we don't judge a lot on these markers because these could be off if we have a lot of bad bacteria or infections. And I can already see below a little bit, you can see the dysbiotic bacteria section, there's some bacteria that are already off. So because we know that, a lot of that normal bacteria may be off, so we don't really worry about it. It's more of an effect, not necessarily a cause. So we keep it in mind, and as we clean things out and we add prebiotic fibers and we change the diet, a lot of times that stuff by itself will kind of come back into balance itself. We don't really get too myopic on that.
Yep. So this overgrowth category,
any comments, Evan?
Yeah, so let's move on to the overgrowth category. We talked about how this person on the right is definitely more sick and symptomatic as the person on the left. It says my internet connection's unstable. I don't know if I got choppy on you for a minute. It should be fine now. But
you're good.
Okay, so you see the Pseudomonas over here on the right. Pseudomonas spp, Pseudomonas aeruginosa. You see the Staphylococcus, different species of that. You see Streptococcus is real high. So even just looking at a numbers perspective, looking at the number of different species of overgrowth bacteria, you could see the one on the right is obviously a bigger problem.
Exactly, 100%. And then the big thing I like to look at is I look at the standard deviation. I see which ones have the same standard deviation that are positive. So off the bat, you can see the staph is 1.08, but it's got one standard deviation above. So it's 10x higher. So that's like an 11. So 5's the reference range. 11's not bad. Next thing I look at this, strep 6, greater than 1. So nothing's like jumping out super high. Bacillus 7.5 e to the 5, 1 point. So nothing's really super high. Now I go over to the patient on the right. Let me see if I can, one jumps out at me here. So you can look at this one. Yeah, Pseudomonas, for instance, right? That's 3.46 e to the 5, the reference range 1.0 e to the 4. So what's that really? That's really 34.6. Well, so the Pseudomonas is really high. That's 34 times above. That's a big deal, right? So I try to look at and say which ones are are mildly elevated and which ones are significantly elevated. What does significantly mean? 10x or above. 10x or above I consider to be significantly elevated. Now, we're not going to do anything specific to target one bacteria over another. We have specific herbal blends that we'll use to work on knocking these bacteria down. And again, these bacteria can produce methane and hydrogen gases that can disrupt motility. It can cause constipation, cause diarrhea. So we want to keep these in mind. Now, a lot of people are like, well, can this tell me if I have SIBO? This is a common question. Yes and no. So we know that certain bacteria like Pseudomonas or Strep or Citrobacter or Prevotella are associated with SIBO. We know that according to the literature, but we can't specifically say because we don't know exactly where the bacteria came from, right? So imagine you squeeze some toothpaste out of the toothpaste tube and you want to know, hey, well, what part of that toothpaste tube was exactly in the middle portion of a tube? Well, it's hard to know once it all came out, right? So with a SIBO breath test, you can know because when you swallow lactulose, you know, and you blow in a tube every 20 minutes, you know based on the time it takes for that lactulose to enter the large intestine, you know kind of where it is. So it takes about 120 minutes to get into the colon or the large intestine once that lactulose breath test is done. So you kind of know if it's within that 120 minutes that it's probably in the small intestine. So we need a breath test to really confirm SIBO overgrowth in general, to be exact. Can we say that it's probably a SIBO overgrowth when we see certain bacteria high? Yes. So we tend to use terminology like, hey, you have just a generalized dysbiosis, and we can treat it and address it and retest. We can also do SIBO breath testing so we can be more accurate with the lactulose and know exactly potentially where it could be based on that timing scheme that I mentioned. So with lactulose, you're blowing into a tube, and then you're blowing into a tube, you get a baseline, then you swallow some lactulose, and then you're breathing into a tube every 20 minutes. So you're going to be able to get about 6 to 8 readings before you know it's in that colon. Does that make sense?
It does, and we just did a whole show on that. So go look back just a couple episodes ago. We did a whole podcast on SIBO, bacterial overgrowth, parasite. So check that one out. Now, here's one section I want to point out here, which is the fungi yeast category. You see here that both of these people tested negative or supposedly negative for Candida spp, albicans, geotrichum, microsporidium. These are different fungi. Microsporidium is technically considered a parasite, but it's confusing. So it's in the fungi category. Now, here's the interesting thing. I don't have these right in front of me to show you, but I know that both of these people had a false negative for Candida. Candida is really tough to find in the stool. We like to measure the organic acids like tartaric acid and arabinose or arabinitol on the urine. So these are false negatives. So people ask about, what's the accuracy? Well, this test is very good, but it does have the issue of missing Candida quite a bit. And I can tell you, because I remember these cases, both of these people had major Candida overgrowth. It just didn't show up. So you can't, this is why a lot of people, they'll try to save pennies and only do one test when they're looking into their functional medicine history. But you can't. You got to have all the puzzle pieces, because otherwise we may only be using antimicrobial herbs and not antifungal herbs. And in this case, that would be what would happen. We would have only used the antimicrobials and not antifungals. But I can tell you, after looking at the urine of these people, they needed the antifungals. So we got them because we had all the picture. The picture was complete with the urine and the stool, not just the stool.
100%. So just kind of looking above real quick, the GI map can tell us generalized dysbiosis. It can give us a pretty good guess that there could be small intestinal bacterial overgrowth, SIBO, based on the bacteria we see, but it can't 100% confirm SIBO. So just trying to get people to wrap their head around that, because that's a common question I get. So I'm going to refer my patients to listen to this podcast for more intel. But to be exact on the SIBO, we need that breath test. The next is a biopsy. Most people are not going to do a biopsy when there's less invasive testing like a breath test available. And now, adding to your point about the fungal overgrowth, the first thing we look at to assess fungal is clinical symptoms. Do we have any fungal toenails or fingernails? Do we have any dandruff issues in the hair? Do we have any tinea versicolor rashes on the skin? Do we have any history of athlete's foot or jock itch, those kind of things? And of course, that tells us there gives us a higher chance that there could be fungus in the gut. That's number one. Number two, we're going to want to address that either way with specific herbs, and obviously we'll want to hit it topically, because sometimes fungus on the body or hair or scalp or skin or growing area or anywhere else still may be a problem. We may have to hit it topically, and that's really important to note. And then we also have the D-arabinitol, which is going to look at fungus from the organic acid perspective. And the organic acid's a urinary test, and that gives us a little bit more of a systemic window into either gut bacteria or yeast. And so that's another test that we tend to combine with this, because I've seen a lot of people come back clean on the yeast or fungus, but the D-arabinitol be very elevated. That's important to keep an eye on.
Yep, all the time. So we've seen much worse than this page 4 here. There's a lot of other cases we could have pilfered through, but these are just the 2 we pulled up today. And according to this, you see that the only thing on the parasite and worm category was the person on the right here had some Dentamoeba fragilis, which according to the lab, they would say this is in a normal range. Now, we'll probably end up killing this just as a byproduct of using the herbs to knock out the other bad guy, so this will probably disappear on a retest. But a lot of times we do see stuff pop up on these pages here, Blasto and Cyclospora and Entamoeba coli. There's some other bad guys on here that can help drive up these inflammation markers. Now, if you go down to the bottom section here, I told you in the beginning the person on the right had way more symptoms. They were way more sick. And look here at the calprotectin level, the inflammation level. You know, we're well above 400 here. So this is super inflamed gut. And I'm surprised that the IgA was as good as it was here. The IgA I expected to be lower, but it wasn't. So either way, this person needs help major.
Exactly. So just recapping, we have the parasites. These are all significant. So if we have a parasite that's close to being positive, so this person here with the D. fragilis at 2.51 e to the third versus the range being 1.0 e to the 5, I'm not worried about that, because this is essentially, let's move it over to the left twice. So we're looking at 0.025, and then that's 1 or greater. So not really worried about that, even though it comes back positive, not worried about it because it's far below the reference range. If it was maybe 50% below the reference range or greater, 50% or up, meaning 0.5 and up e to the 5, same as the reference range, then, we're going to work on treating that for sure. And so we have all these parasites here. We have worms, and we have different protocols for worms or for parasites. And we have different protocols if someone has a worm, a parasite, fungus, and bacterial overgrowth together. And we may sequence things differently. So there's a lot of different combinations in how we may hit things depending on what else is coming back.
Yep.
Any comments there, Evan?
No, this is all good. And then what do you want to say about the
intestinal health
response here?
Yeah, so let's kind of hit one by one. So steatocrit's very important. If we can't break down fat, that tells me that we have poor biliary output. If we have poor biliary output, there could be stones or sludge in there. That could be from estrogen dominance. It could just be from inflammation in the gallbladder. It could be from poor stomach acid levels from gut stress and from SIBO and from infection. So we have to follow the 6 R's. We remove the bad foods. We replace the enzymes, acids, and maybe bile salts if we have increased levels of steatocrit, because we have to be able to break down fat. Remember, bile is antibacterial, right? So if we don't have enough bile and we've had chronically low bile, steatocrit will be higher. And if steatocrit's higher, that means bile's lower long-term. Bile's antimicrobial. So with lower levels of bile for long-term, that can actually drive bacterial overgrowth. So we want to make sure steatocrit's adequate. We want to make sure elastase is good. If we have low enzyme output, I automatically go to the fact that we probably have low hydrochloric acid too. And we're going to supplement HCl and enzymes separately. If we see steatocrit there, we're going to add an extra biliary support in ox bile as well to help with fat breakdown. Now,
let me mention here that with the H. pylori infection, I'm kind of surprised of 2 things on this one on the right here, that the steatocrit is below detectable limits, because a lot of times we see H. pylori and high steatocrit on the same panel, and then the IgA. I'm surprised the IgA is not lower, meaning the gut barrier is less intact. So maybe that means that the person was doing really good with diet, but I don't think so with the calprotectin being so high. Maybe, I don't know, maybe it's a relatively new infection. The IgA is better and the fecal fat's not there. I don't know. I don't know every detail of why things show up the way they do, but it was just surprising to see that.
Exactly. So, it's important. So when we see, you could have digestive issues and some of these markers could look okay. So there's an art and a science to what we do. So it's not just, well, the test says this, therefore, we're not going to give you support, because we're not treating a piece of paper. We're treating a real life human being. So we have to look at the total picture. We have to look at the labs. We have to look at clinical markers, clinical indicators, hair quality, nail quality, skin quality. We have to look at the whole picture, right?
Yep.
If we see poor nail and skin and hair quality, well, we're thinking there's probably some digestive issues, especially with breaking down fats and protein, even if this test says we're okay. So next thing is we look at beta-glucuronidase. That tells me there's probably some bacterial overgrowth, which beta-glucuronidase gets made by bad bacteria. So we like to look at that as well as the other markers for bacterial overgrowth, like the actual bacteria themselves. And then, of course, that's going to screw up estrogen metabolism. So we may, if it's a female or a male that we're having high amounts of estrogen symptoms, we may give things like calcium deglucarate. But a lot of times just fixing the digestion and getting extra sulfur nutrients in there can help a lot of that, so we can start breaking down and escorting out those remetabolized hormones, those recirculating estrogens. We may give extra fiber or vitamin C as well. It just depends. But when I see beta-glucuronidase high, I'm thinking hormonal issues, and I'm thinking also bacterial overgrowth issues too. And then
just general toxicity, because you're recirculating toxins. So when we see mycotoxins high, if we look at chemical toxins high, we know that person is recirculating all their toxicity. So we really have to prioritize that when we see it high.
Exactly. And then the next thing is occult blood. Of course, if we see an H. pylori infection, we're thinking, oh, hey, is there an ulcer? Is there any blood in the stool? Is there any redness in the stool? Most of the time we see blood that's going to be in the stool, we're thinking, hey, maybe there's just hemorrhoids, right? Those hemorrhoidal veins in the anus, they get inflamed with people chronically bearing down, and sometimes a little bit of blood can come out through those veins. And that's not necessarily as big of a deal as, let's say, an ulcer in the upper gut tract, or something in the small intestine like a duodenal ulcer. So we have to kind of draw a line between ulcerations in the intestinal tract and maybe a little bit of blood coming out from the hemorrhoids. So of course, if we see any occult blood, we ask, is there a history of hemorrhoids? And most of the time there's yes. If we're not sure, then we'll look at, hey, is there any anemic patterns? Low B12, low iron. We'll run a full iron panel as well. We'll run a full CBC with indices, so we can get a window to make sure it's not affecting the overall blood and iron levels and hemoglobin levels. Okay, any comments there?
We've seen it really high. In these cases, it was 0, but we've seen it high, and it's a great, very helpful piece of the puzzle.
Exactly. And the next thing I would say is the IgA levels. And again, IgA, it's good to look at. We don't go all in on IgA. If we see extreme high, we're thinking maybe there's an active infection and the immune system's going after it. If we see low, we think maybe there's some chronic stress and that immune mucosal barrier has been weakened due to inflammation from food, infections, poor digestion, emotional stress, or etc. We don't go all in though. So it's not like, hey, this is low, we have to, go all in and target that. I call these peripheral markers, meaning they're an effect, not a cause. So the IgA is going to go up because of other things. That's not going to be a problem in and of itself. We have to look upstream to get to the root issue. So we keep it in mind, but it's not going to be something we get so myopically focused on. And then, of course,
it'll often self-regulate. So if it's too high and you fix the bugs, it'll go back to normal. If it's too low and you remove the infections damaging the mucosal barrier, then it can come back up on its own. And sometimes it does need special care, but a lot of times it does self-regulate.
Exactly. And then again, we have the gluten antibodies. That's a big deal, because if we are gluten sensitive and we're consuming foods that are making us weak and jacking up our immune response or weakening our immune response, that's a problem. So of course the gluten markers are a big deal, and we got to keep that in mind. And it may not just be cutting out gluten and avoiding wheat, barley, and rye, right, which are our gluten grains. Really, that's just gliadin. And maybe cutting out all grains, because glutens, just like brothers and sisters in a family, they may look similar to their aunts, their uncles, and their cousins, right? There's a family resemblance. And so our immune system still sees that family resemblance to other types of gluten grains like rice or oats or corn or even pseudo grains like quinoa. So we may have to cut out all grains and go 100% grain free. And then of course the other X factor is going to restaurants, there could be grains or flours or thickeners in sauces. So if you're going out to eat and you're trying to be 100% grain free, stick with steaks, stick with things that don't have sauces on it unless you know exactly what that sauce is.
Yep, well said. The calprotectin, look at the huge difference here. I mean, despite both of them having bacterial overgrowth. We see calprotectin here at a 3, no issue, and then over here we see 400, which is really high. We've seen higher, but I mean that's a significant problem, and I would say this is more of an effect as well, right? I mean, you're not going to say, hey, we're going to specifically go after calprotectin. However, I often will throw in, I've got one I call GI Soothe 2, which is just a straight aloe extract. I often will, if it's this high, throw in just a little bit of some aloe or something else to try to hurry up and get it down, even while we're working on the bad guys.
Yep. Calprotectin is basically C-reactive protein, which is a systemic inflammation marker for the blood. It's a systemic inflammation marker for the gut. Calprotectin is produced by the white blood cells in the gut and in and around inflammation. Here's the thing. You can still have inflammation in your gut, in your tummy, and not have high levels of calprotectin. So it's not a catch-all. It's not perfect. Yeah. But if we see calprotectins there, we keep that in mind. There can be some false positives regarding calprotectin. And of course, there can be false negatives, meaning not that calprotectin's high, but it came back negative, but more like you still have inflammation in your gut. It's just not coming back with calprotectin. So it's not a be-all or end-all, but if we see it high, it can lead us that there could be some irritable bowel disease like Crohn's or ulcerative colitis or microscopic colitis, which is important to know. People that have irritable bowel disease, right, those type of conditions that I just mentioned, they have to be more strict and they have to be more extreme with the diet. And like Evan said, we're going to be adding in more healing and soothing compounds, aloe, DGL, L-glutamine. We're going to be adding in bone broth, things that are very soothing for that gut lining to calm down the inflammation. And of course, that's an effect, not a cause. So we're still going upstream to all of the things we just talked about earlier.
Yeah, I like that you mentioned here. So this person, you're not going to necessarily get them off the hook just because their calprotectin was low at 3. If they're reporting gut inflammation symptoms, there's like major bloating or there's burning or there's just stomach pain, we may still use gut healing nutrients now with this person, even though they didn't show up high. So I like the point you make that it is kind of an art and a science, because there's a lot of people that they expect to look at the number and then have a game plan just based on the number, but it actually goes deeper than that.
Exactly, and I see a lot of people that are doing these tests on their own and they're trying to self-treat, and it's a big, big mistake because you have to look at the clinical picture. I have people that want to reach out to me and just want me to review the test. And I'm like, no, I need to know the whole clinical picture. I need to know everything about that patient, their history, where they're at, and then I connect it to the results. So you have to look at everything, and people really make a big mistake. And that's why you want to have a good functional medicine doctor that can connect the history to the labs. Super important.
Let's talk about the antibiotic resistance just for a couple minutes, and then I got to run. But on the right here, let's talk about this one, because this is the person who did show up with the H. pylori. How would you approach this page if, let's just say that everything were positive, and they're going to go to their gastro doc, and they're going to say, hey, gastro doc, I've got H. pylori, but now I'm showing up. They don't, but let's say in this case, because we've seen it a lot, amoxicillin shows positive, clarithromycin, fluoroquinolones, all show positive. Then what?
Yeah, so when we look at some of the markers here, for instance, these are different families of antibiotics. So for H. pylori, there's what's called triple therapy. That's amoxicillin, clarithromycin, omeprazole, right? Amoxicillin, clarithromycin are antibiotics. So they're looking at resistance of the H. pylori to the antibiotic. So obviously nothing came back there. Then you have the fluoroquinolone family, which is sometimes used. That's going to be, has a lot of side effects in the literature with mitochondrial damage. Fluoroquinolones are also known to destroy ligaments and tendons. A lot of Achilles tendon rupture associated with these. So we really want to avoid fluoroquinolones at all costs. So fluoroquinolones will be Levaquin, Cipro, those kind of things. Got to be careful with those. Tetracycline as well. It's not going to have the same side effects as the fluoroquinolones. And then we have different families of antibiotics, right? So B-lactamase is going to be things like they're going to be penicillin derivatives. That's going to be cephalosporin, et cetera, typically penicillin derivatives. So if we see B-lactamase positive, then we probably want to avoid, if we're going to go down the antibiotic route, the penicillin derivative antibiotics. Again, for us, it's not a big deal because we're not using antibiotics like a conventional medical doctor would. So it doesn't really help us a ton. But if people have gotten antibiotics in the past and we say, hey, you haven't gotten better, it's nice to connect the fact that, hey, there may be some genetic resistance. So you can see that.
Pointing that out. Yeah, because we'll have people that say, hey, look, Dr. J, I already did triple therapy, and then they come to us, and guess what? They showed positive for all the ones that they did in their triple therapy. So it's at least nice for us to be able to explain to them why they failed in the past. And sometimes that alone just makes people feel better.
Exactly. And then we have the macrolides down here, which essentially clarithromycin up top is a macrolide. So these are different families. They use these at the top because these are the most common. They call it triple therapy, or Prevpac is what's used for antibiotics, but clarithromycin's in the macrolides family. So you have like Zithromax, azithromycin, erythromycin, you have clarithromycin, Biaxin. These are different macrolides, and then you have vancomycin by itself. So these are different antibiotic families that are going to be used to address the infection, but we're not using that, but it's nice to know if there's resistance and connect it back to the history. All right, anything else you want to add there, Evan?
I would just say the point that you already said, but I'll say it again, is that you can't just look at this lab and expect someone to review this lab for you and make a protocol. And if they do offer that service, I would be skeptical of that service, because that's not how it works. You can't just look at this and have a full picture and then, hey, I'm going to make a protocol based on these numbers and get you better. If you're just in a vacuum, you've got no history, you've got no information on sleep and diet and stress and relationships, and you've got no clue what they've done that's helped and no clue of what they've done that hasn't helped. I mean, I just don't want people to over-focus on that by itself. You got to have the full case history. You got to have the full review, because you just won't get better if you don't. History
is half. Labs are the other half. And really important. So anyone listening that wants to take the next step, feel free to reach out to Evan Brand at evanbrand.com. You can reach out to Dr. J at justinhealth.com. We're available for consultation worldwide if you want to dive in. And if people aren't ready to take the next step, just use this information. It's totally free. Get your health better. If you have family or friends that could utilize it as well, just give us a share. Sharing is caring. We appreciate it. Put your comments down below if you're enjoying it. Let us know what you think. I know Evan's got to run to a patient. I do as well. So Evan, wish you the best. It's Thanksgiving Day week, so you have a great Thanksgiving Day with your family, and everyone listening, have a phenomenal Thanksgiving as well. Everyone, you guys take care.
You too. See you later. Bye.
All right, bye.
Got a question for Dr. J? Go to BeyondWellnessRadio.com and click the questions button. Then tune in to hear the answer. Also, if you like the show, click below to review us on iTunes. For more Beyond Wellness Radio, go to BeyondWellnessRadio.com.